with standard of care. Okay, so standard of care and outcomes. This is one of the most important things as a clinician. Your outcomes should be clinically meaningful outcomes. So if I'm looking at bisphosphonates, fractures would be the most valuable clinically meaningful outcome. And then, of course, secondary outcomes can be things like BMD, safety, etc. Another thing that you need to be looking at is the timing of the study. So I often find it super helpful because I do a bunch of systematic reviews. And as you know, it's very hard to come up with new topics and come up with marvelous ideas for systematic reviews. But one thing that I find is super helpful is literature often doesn't break it down into time spells. So I've done a bunch of reviews on existing topics, but justifying a publication by saying that short-term versus long-term is often helpful to look at. So I want to make sure that you guys are not confused here because I am talking about a PCOT format for two different reasons. So if you have a primary study, you can break it down as you're reading it to the PCOT format. But also, if you have a clinical question, you should be able to use the PCOT format and formulate that into a research question. So it's a bidirectional thing. And this example is to show that a clinical question can be broken down into a research question using this format. All right. So I said I have three themes that I'm discussing. The first theme was the PCOT, to be able to identify the population, intervention, etc. And the second part is called the internal validity. All right. So internal validity, why am I getting frozen? Okay. So internal validity, we break that down into bias and confounding. So bias is any finding that systematically differs from the truth. Either it might be how we selected the populations, how the controls, etc. So anything that systematically differs from the truth is called a bias. And confounding is a particular type of bias that we will get into. So I broadly break down bias into two larger categories. One is the selection bias, and the other one is measurement bias. So these are more applicable to observational studies, so maybe a cohort study or a case control, which I will briefly get into. But if you're looking at an observational study, there are two types of biases. So one is selection bias. I have a good example where for my master's, I ended up looking at stroke outcomes post breast cancer patients who are on tamoxifen. So, as you know, as hormonal therapy, tamoxifen and aromatase inhibitors are available after the initial treatment for ERPR positive patients. And when you're doing an observational study, you're looking at previous data, whatever happened before. So there's a selection bias. For example, if a patient previously had DVT or PE, chances of they being put on the tamoxifen group is actually less. As we know, tamoxifen increases the risk of venous thromboembolism. So there itself, we have identified a selection bias in an observational study. And that's just one example of a type of selection bias. And that's actually called, I think, confounding by indication, because based on the indication, you've actually selected out a population. Measurement bias, similarly, if you, for example, I'm just quoting one or two examples for each category. Measurement bias would be administering a survey, for example, for patients with cancer and no cancer. And a patient with cancer will remember so much of information about their family history, their cancer journey, etc. Whereas a person without cancer will have have difficulty recalling some of the nuances. So there you're actually introducing a measurement bias. So remember, when you're critiquing, especially your observational study, try to identify if there are selection biases or measurement biases. Confounding is a big term, especially when you're looking at observational studies. And I will start with a definition. So for the trainees, I would urge you all to remember this definition. There are 3 criteria for it to be a confounder. And I know this becomes important, especially for your postgrad. If you're doing any type of study, you need to be able to write a separate section on what are the potential confounders of my study. So the example that I have here is I'm going to say that coffee drinking causes acute coronary syndrome. So my exposure is coffee drinking and outcome is ACS. But I know smoking is actually associated with coffee drinking as a cohabit. People who smoke may also drink coffee at the same time. Smoking, we know, is associated with acute coronary syndrome. So we are going to look at the effect of smoking as a confounder when we are looking at coffee drinking and ACS. So smoking here would be a confounder. For it to be a confounder, there are 3 criteria that need to be met. It needs to be associated with the exposure and the outcome, and should not be in the intermediary pathway. What that means is coffee drinking, its mechanism to cause ACS has nothing to do with the intermediary pathway related to smoking. Smoking is separate. So this may sound a little bit unfamiliar for some of you, but I would encourage to spend a little bit of time knowing these 3 criteria for a confounder, especially down the line. If you're looking at formulating a study, you will have to come up with a list of potential confounders in your study. So again, 3 criteria. A confounder is associated with the exposure and the outcome, and it's not in the intermediary pathway. All right. So if you do identify confounding, you can stratify it and create separate groups as smokers and non-smokers. And you can also do a what is called an adjusted analysis in the availability. Given the availability of time, I won't go into details, but you can do what is called a regression analysis, where you statistically control for smoking, BMI, etc. And then when controlled for these variables, you can come up with estimates for the exposure outcome that you're interested primarily. Okay, so this is a very skim approach to epidemiology, but I'm hoping within about 45 minutes, we'll at least get your feet wet with some of the nuances and basic principles of epidemiology. So where are we now? We talked out of the 3 principles, the PCOT format, and the second thing is internal validity. We broke down the internal validity into bias and error. So we covered bias, but what's important to note is in RCTs, we inherently randomize patients, and most of the confounders and biases that we talk about may be smoking, may be BMI. So those are called unmeasured confounders in a clinical trial. Just based on the fact of randomizing, one of the advantages is some of these unmeasured confounders will be balanced out between the 2 groups. So larger the population size, as you know, some of the cardiovascular trials will have thousands of patients enrolled, and the idea is some of the unmeasured confounders will actually be balanced, and that's one of the biggest advantages of a RCT. Someone asks you what are the 2 main advantages of RCTs. One would be through randomization to balance out unmeasured confounding, and the other one is causality. As you know, RCTs is the only study design which would prove causality. Okay, so getting back to RCTs, what I want to say is, since we have randomized patients, this whole concept of bias is somewhat taken care of. Still, within a RCT, there are a couple of things we need to look at, whether it was done properly to make sure the groups are quite comparable. Okay, so I will get back to sample size, but for internal validity of a RCT, instead of looking at the selection bias and the measurement bias, we actually look at other separate criteria, which is randomization, treatment allocation, blinding, and analysis plan. So these are the 4 things that you should be looking at when you're critiquing a RCT. You should be able to specifically look at the randomization. Was it standard enough that randomization actually happened? Treatment allocation. So are we allocating patients to different treatments in an unbiased way? What that means is, me as the clinician, if I have patients coming in to be enrolled to a trial, and the patient who walks in, if I know that this next patient is going to get treatment A, I'll be biased there because I'm like, oh, this patient I know personally, treatment A I feel is not as good as treatment B. So there you're introducing a bias. So the treatment allocation should be predetermined irrespective. Blinding, again, if you start reading RCTs, the most popular term that they use is double blinding. I encourage you not to use the term double blinding. Instead, look at the different components and the people involved in a trial to see whether they're blinded. For example, the patients do need to be blinded. The people who are administering the intervention need to be blinded. The people who are measuring the outcome should be blinded. The people who are analyzing should be blinded. So there are different categories of people that need to be blinded, and just blindly saying double blinded may not be the best option. And essentially, right until the time of interpretation of the data, it is expected that that whole trial will be blinded for the different types of groups. So the analysis plan, the standard analysis that is done for clinical trials is called an intention to treat analysis. What that means is, we consider a patient in a particular group at the time of randomization if they were allocated to treatment A. Down the line, if they stop treatment or move to another group, it doesn't matter. The initial intent was to treat them with treatment A. So that's called an intention to treat analysis. And they say that that's the best way to simulate how the real world would work. And the standard way of analyzing in a clinical trial is based on an intention to treat analysis. That means you analyze based on their initial allocation to treatment. Per protocol analysis is the opposite, where you actually analyze based on their current treatment. So if patients move between groups, you actually analyze based on their current treatment regimen. So again, I'm saying, for internal validity of a clinical trial, to be able to talk about randomization, treatment allocation, blinding, analysis plan. And if it's an observational study, you look at biases and confounding. We said biases, there are 2 types of biases: selection bias and measurement bias. Okay. So I'm going to keep sampling and recruitment for maybe just my next slide. And that's essentially the 3rd point, looking at the external validity. I am going to talk very briefly about a couple of considerations of RCTs. So this is another good checklist to have when you're critiquing a RCT, specifically looking at the inclusion and exclusion criteria. Okay. So the exclusion criteria, are they so stringent that they are taking away patients with stroke and renal failure, etc.? So this needs to be explicit, and especially if you're doing a journal club, it's very nice to have a separate slide on the exclusion criteria. This becomes important because this then translates into the generalizability of the study. As you know, clinical trials try to have their population very homogeneous so that those patients will endure to the end of the trial so that they can measure the outcomes. But in the real world, it doesn't help us, right? So most interventional trials that are done have a selected group that's otherwise healthy that will live through the trial and endure the outcomes that we are measuring. Unfortunately, that actually reduces the generalizability of the study. So look at the exclusion criteria. Look at the control group. I think that's a big critique that everyone as clinicians need to focus on. The control group should be standard of care. And believe me, this is not practiced in most clinical trials. You really need to hone down and think if the control group has standard of care that's currently accepted, because if not, there's no point doing a trial by selecting an inferior control group. Crossover is also important. So what crossover means is if you're doing treatment A to a group and then down the line moving then to a treatment B, that's called a crossover design. And again, I won't go into too much detail, but the problem is, I'm sure this is relevant in ICU literature as well, where you have patients on treatment A, move them to treatment B after some time. That helps manage when your sample sizes are actually quite small. You're able to study different interventions using the same population. But remember, if it's a crossover design, make sure there is enough washout period. What that means is there should not be any residual effects of treatment A. It should be completely washed out before treatment B is started. So if you're doing a crossover design, particularly look at the washout period. The outcomes, I emphasized this already. As a clinician, you should be advocating for clinically meaningful outcomes. If a study is done based on the example that I gave you before, looking at osteoporosis, true enough, BMD will be an important outcome, but you as a clinician should want clinically meaningful outcomes like fractures. So when you're critiquing an RCT, look at the type of the primary outcome that they've looked at. Is it clinically meaningful? All right. And this other concept of clinically meaningful difference will probably make sense in 2 slides from now. But what that means is, again, I'm trying to crunch so much of information about clinical trials and designs and stuff within a very short period. But as you know, and there are fundamentally 2 types of trials: superiority trials and non-inferior trials. So superiority trials is your day-to-day clinical trials that you see. There's a new intervention that comes to the market that people are interested in, and you compare that for superiority. But sometimes non-inferior trials are also important, where you introduce a different way of doing something. For example, a reduced dose maybe, or the frequency of the same medication you would want to trial once daily versus once weekly. So those type of trials are called non-inferior trials. And the important thing about a non-inferior trial is beforehand, you need to decide what a non-inferior margin is. If I clarify that, what that means is before we start the trial, we would say something like up to a 2% difference in outcomes between the groups. The group who gets once daily treatment versus the group who gets once weekly treatment. And if the outcome is to look at MI, we would say up to about a 2% difference between the 2 groups would be considered okay. Or in other words, it's within your expected a window that you're accepting that the treatments would be similar. So look at this specifically, especially in a non-inferior design, what that clinically meaningful difference is. Why I caution this is sometimes they look at cardiovascular outcomes of MI and stroke and all that, and have a clinically meaningful difference of 25%. What would that mean? So the trialists are saying up to about a 25% difference in outcomes are acceptable for them for the interventions that they're looking at. And to me as a clinician, doesn't make a lot of sense. And this is why your critical appraisal skills are super important. You guys are going into your independent practice, and all of your clinical acumen is so valuable, and to be able to use your clinical acumen to critical appraisal and be able to say this does not make sense would be a really important skill to have going forward as independent clinicians. So I've given you some structures when you're critiquing RCTs. One set of things is to look at the actual trial design. And the other set is to look at some of these nuances like exclusion, control group, crossover, outcomes, and clinically meaningful difference. Okay. So we are still in the second principle of internal validity. And when we talk about internal validity, there are two terms that come up when we look at errors in statistics. So errors can be an alpha error and beta error. I know at some point, I'm sure you all have heard this term, but I'm going to overly simplify this. When we do a statistical analysis, sometimes when there is no difference in the two groups, we still identify as having a difference, and that's called a false positive or alpha error. So if I repeat that, we compare two groups, they are supposed to be similar with no difference, but statistically we make an error and identify a difference, and that's called a false positive or alpha error. And the reverse, when we compare two groups and they are meant to be different, okay, still if we don't identify a difference, that's called a false negative or beta error. So just be familiar with those two terms. So conventionally, if you're critiquing a paper, your alpha is set at 5%. What that means is there's a 5% chance of the observed results being due to chance. And this is how the 95% confidence interval comes as well. What that means is from the observed difference that we have. For example, if you are looking at the differences in death rates between two groups, we might say ratio is 1.4, for example, and I have a confidence interval of 1.1 to 1.7. So what that means is if we do the study 100 times, 95% of the time, the value of mortality will be between 1.1 to 1.7. All right. So that's based on a 5% 5% false positivity. Beta, on the other hand, I said it was a false negativity, and that's usually set at 80% of power. So conventionally, when you're looking at a paper, be able to comment about the alpha error and the beta error, right? Next slide, I'm going to take you to a little bit of an elevated this thing. We often talk about sample size calculations, and I know it's sometimes over your head when you do a sample size calculation, but I'm going to very simplify it by saying the concept of a sample size calculation is based on four things. So the alpha and beta we already talked about. We said conventionally we set up alpha at 5%, and conventionally we set up beta at 80%, and we call it 1 minus beta, which is the power is considered 20%. But simply speaking, alpha 5%, beta at 80%. The two other variables we put into when we are calculating a sample size are the event rates of the two interventions that we plan to do. So if you're comparing drug A and drug B, we as clinicians, we would say we are going to consider drug A as superior only if we see a difference of 20% or more. So supposing in your ICU literature, you're looking at mortality, and you're having this new, let's say, something to do with hemodialysis or CRRT, and you say, okay, this new intervention, if I see a 20% of or more improvement, is when I would consider this a important intervention. So that's a clinical decision that you're making, and preemptively you decide on the event rates. So in other words, if you're doing this trial, you would know your alpha, you would know your beta. Based on the current standards, you know that the mortality rates for these patients, for example, I would say 30%, okay? But with treatment A, you're expecting this 30% to go down by another 20%. So I won't do the math here, but this is how you would preemptively decide on the event rates So if you know the event rates for treatment A and treatment D, these are hypothetical rates that we decide on. If you know the event rates of A versus B and the alpha and beta, these are the 4 components that are needed to calculate a sample size. And again, this clinically meaningful difference comes here as well. We need to be able to decide up to if this new intervention is only going to change mortality by 1%, we are not interested. It doesn't actually work. It's not worthwhile all the money and the effort spent on this new intervention. You as clinicians should be able to critique and say, this study doesn't make a lot of sense because they say even up to 2% difference is a significant difference, but that clinically doesn't make sense. So, and that's why I put this slide to be able to, when you're reading the section on sample size calculation, you should be able to comment on that and see how they have actually calculated the sample size. I'm hoping, so this is a little bit of a heavy slide, but I'm hoping it actually made sense. So where are we now? We had point A, which was the Pequot format. The first principle was the Pequot format. Second principle was the internal validity. And we said internal validity was bias and error. We introduced some new concepts for internal validity when it's the RCT. And the third concept is quite simple, is the external validity and the generalizability. So when you're critiquing a paper, you should be able to confidently say, you know what, based on the population that they selected, based on the exclusion criteria that they had, how relevant is this to my day-to-day patients? Is it relevant to the demography that I'm treating with? Have they included the appropriate ethnicities, and is it relevant to my Sri Lankan patients? So this is how you would make a clinical judgment based on the eligibility criteria, the inclusions and exclusions, and how they recruited patients, etc. You would then comment about the external validity. To make this judgment, it's often helpful, as you may recall, some of the trials actually have this flow chart that they say they initially identified 500 patients, but based on their exclusions, they excluded 80% of the patients that left them with, let's say, only 50 patients, etc. As you can see, my math knowledge is not great. I'm just quoting numbers. But if the trial is so stringent that they impose so many exclusion criteria, that significantly restricts our generalizability of the study. Okay. So this is what I want to emphasize. I think I've given you a structure to work on as a critical appraisal. So this is not just to present at journal clubs. You as clinicians, you have such a busy schedule. Looking at a paper, if you actively look at these points, what's the Pequot format? What's the internal validity? Internal validity is bias and error, and what's the generalizability? If you're able to answer these 3 questions, I think you've done a fantastic job. Okay. Okay, how about we for time? I think we have about 20 minutes. I have a couple of things extra that I am happy to talk about. Organizers, what do you think? Can we spend another 10 minutes or so, or shall we leave it for more questions and stuff?
I think we can go through that as well, Tivanka, and having that, I think we will have some time for the questions also, isn't it?
Okay, fantastic. Okay.
Right. Okay.
So when you're designing a study or looking at a study, you need to be able to comment about the outcome that's actually measured, right? So the next couple of slides is I'm giving you some generic information about clinically relevant outcomes. The first thing is clinically meaningful. I've emphasized this over and over again in my osteoporosis study. I don't care about BMD. Well, BMD is important, but I care more about the fracture. So advocate always for a clinically meaningful outcome. Your outcome should be reliable. In other words, reproducible each time you do it. And even if multiple people do it, there should be reliability and reproducibility. It should be accurate. and it should be responsive to change. So if you're doing an intervention, let's say a blood pressure medication, that should change based on the intervention that you do, and it should be interpretable. So this might help kind of conceptualize this. As you can see, the bottom right is the only time where both reliability and validity are both applicable. The others are either not valid or not reliable. So that's more of a conceptual thing. But this slide, I would actually encourage you all to take a minute and read. If you can take a screenshot, I think this is actually one of the most useful slides. So this summarizes the type of outcomes that are captured in clinical literature. Okay, so I want you all to take a minute. This is also a very heavy slide, but this is a really nice summary slide to be able to be familiarized with the lingo that's used. Okay, I'm going to walk you through this. First, look at the columns that I use. So there is a continuous category, there's a binary category, and a time to event category. Okay. Continuous is very simple. So if our outcome is weight, blood pressure, those are continuous measurements. If the outcome is cure or mortality, those are binary measurements. It's yes or no. Time to event might be a relatively new concept to some of you, and this is a very important clinical concept to know. If I were to use an antibiotic to prevent relapse of, let's say, spontaneous bacterial peritonitis. So being an internist, all my examples are the cardiovascular, cancer survivorship, or related to something in internal medicine. I apologize for that. So let's say I'm using ciprofloxacin versus levofloxacin to prevent future SBPs in patients with cirrhosis. So there, if I have a patient who has SBP 1 year down the line versus another patient who develops SBP 3 years down the line, who has the better outcome? It's the patient who has the outcome 3 years later. And I'm sure all of you all agree, because I was able to, with my antibiotics, suppress not developing SBP for another good 2 years. So if you are doing an analysis, we need to be able to account for not only whether they develop the outcome or not, but the duration of that outcome as well. And that's why time to event analysis are super important in clinical literature. And if you look at most clinical trials, they actually incorporate a time to event analysis. All right. So in the same lines, when we use statistical tests, if it's a continuous variable, we use something called a t-test, comparing blood pressure measurements, for example. If the sample size is very small, and in fact, statistically, we say if the sample that you're looking at is less than 30 patients, you actually, we consider these patients being not normally distributed. And again, I'm introducing so many concepts. But essentially, when the sample size is small, they may not be representative of the general population. And you need to account for that by using a different type of analysis, and that's called the Wilcoxon rank test. If you have more than 3 groups, we do an ANOVA test. If the outcome is binary, we use something called the chi-square, which I'm sure you've heard before. But in the cells, if there are any cells less than 5, we use a Fisher's exact test. Similarly, if you're doing a time to event analysis, we use a survival analysis, and the outcomes are called hazard ratios is what we come across. So I think the term hazard ratios is super important for you guys to know, especially if you're looking at clinical trials with a time to event analysis. There's a lot of rushed information here, so I'm very cautious about not introducing too many things. This is usually like a 2 to 3 hour workshop that I take time, show examples and this thing. And the whole purpose is for you guys to get familiarized with some of the terms. And the term multivariant test is Can you remember I talked about when there is smoking and BMI and all these variables that can affect your results? You actually do an analysis controlling for those variables, and that's how you come up with a multivariant test. And these are the type of tests that we used based on whether the outcome is continuous, binary, or a time to event. Okay. So and again, important slide, be familiar with the terms, because all what I want is when you're reading a paper, you should be able to say, oh, they've actually used a survival analysis and say, oh, that's actually a time to event analysis. At least that amount, if you're able to grasp, I think that's super important. Okay. So I think I have another 4 minutes or so. We might shift gears here. What I want to say is in your clinical setting, there are different types of study designs you might come across. I have some clinical scenarios. Let's say for chemotherapy, we want to study the usage of dexamethasone in your unit, and that's usually done as a medical audit. If you want to look at congenital abnormalities with COVID-19 infection, you're not going to give COVID-19 to patients and compare people without COVID-19. You'll actually do a retrospective study, which is going to be an observational study. If you want to look at improving hand washing within your unit, you will actually do a quality improvement study, because you're going to have all these interventions for hand washing and going to see the percentage of people who adhere to it. So that's a quality improvement study. Again, if you want to look at more broadly the risk of stroke with tamoxifen and what's out there in literature, you might end up doing a systematic review. And if you're comparing two interventions, we already talked about this at quite length, you would do a randomized clinical trial. So again, I want you to get familiarized with the concept of different study designs, and especially at your postgraduate level, I would imagine you would do a lot of medical audits, quality improvement studies, or systematic reviews. Systematic reviews is something that I really, really advocate for. I probably spend 60% of my time doing systematic reviews. If anyone is interested, do reach out to me. I'm more than happy to talk more about it. So I just want to introduce the concept of observational studies. Y'all, I'm hoping know the concept of cohort studies and case control studies. So cohort studies is when you look at different exposures and look at the outcome. Use of tamoxifen, whether or not they develop stroke. You start with the exposure and look at outcomes. When the outcome is very rare, like cancer or something extremely rare, then you can start with the outcomes and look at exposures. So those are the two types of observational studies that you need to be familiar with. There is the cohort studies that you start with exposure and look at outcomes, and case control studies that you start with the outcome and look at exposure. I'm going to leave it very simple. There's lots of things that I can talk about, but I'm going to just leave it there just so that you know the fundamental difference between cohort and case control, right? I will not go through this example, but my last two slides is about a very basic prelude to quality improvement studies. Everyone is not going to be academic. Most of you all would be day-to-day consultants, clinicians in your hospitals regionally. So to be able to grasp a very simple quality improvement study is super important. So let's take this hand wash examples. Let's say in your unit, the hand wash uptake is very, very low, let's say in your unit. So you want to improve that from a current 20% to 80% over 6 months in your unit. You just created an aim statement for your quality improvement study. You have identified the location you want to do it. You have identified the time duration within which you want to achieve it, and you have quantified the expected improvement. You're going to improve it from 20% to 80%. So your aim statement has 3 components. All right. So process measures are what are the changes you have to do in order to get there, and balancing measures are how onerous is it? What are the compromises that you need to do in order to get there? So remember, quality improvement studies, you need to focus on 3 things: the aim statement, process measures, and balancing measures. So these are the 2 terms that I just want to introduce in a quality improvement study. there's something called the fishbone diagram. So this is like a analysis where you say, okay, in order to achieve this hand washing, what does it entail from a systems point of view, from a people point of view, and you always ask the question, okay, what does it entail, and do we call it a causation analysis or a fishbone diagram. So as you brainstorm, you would come up with this type of fishbone diagram. So that's just one concept. And the other one is, over time, you should be able to document your outcomes, how that changes, and that's called a run chart. So I'm just introducing the two terms, a fishbone and a run chart. When you're doing quality improvement, you'll often come across this. Okay, so I'm done. So the last component was essentially talking about the different study designs and just giving you a very, very brief overview so that once you start reading papers, you'll at least know what they are referring to. All right. I would end off by showing you this example of when you're stuck and don't know how to critique, and you don't have a framework. This is often useful. So if you Google these terms, for example, if you're looking at a RCT to critique, you can use the consort statement. It gives you a checklist of what a proper RCT should look like. Similarly, if you're looking at observational study, you can use the Strobe statement. For systematic reviews, you can use the Prisma statement, so on and so forth. And for bias assessment also, there are specific tools called the Cochrane tool and the Newcastle Ottawa scale. So just be familiar with these. You can always Google these terms and use these checklists when you want to critique a paper based on the study design. Okay, so that's about it. I do apologize. I had pressure of the speech and pressure of thoughts because there was so much to cover, and I really wanted to maximize the time duration that I have to at least introduce some of these terms. As you know, this can be a week-long workshop, but I felt that I should at least get you guys exposed to some of these terms.